everyone, welcome to the webinar. Today's webinar will be presented by Sarah Flatt from Teton Therapy in Wyoming. And so let me transfer you over to Sarah. Okay, Sarah, here you go.
Alrighty, so kind of like Mohini talked about, I'm going to be presenting a case about a diagnostic ultrasound I did on a hip. So a little background about Wyoming. We're very rural around here. I performed the ultrasound in a town of Riverton, Wyoming, small population. And there's currently no orthopedic surgeons in Riverton. So the majority of patients leave the county or the state to get orthopedic related surgeries. Some surgeons do come to Riverton maybe once or twice a week for follow-ups. So we're a very medically underserved area. So it's kind of exciting that we've started doing the diagnostic testing to better treat our patients and get them answers quicker. So here is a little map, a little visual. So Riverton's located kind of right here in the middle of the state. The closest orthopedic group is located in Lander, which is about a 30-minute drive. But the two bigger facilities patients go to are either in Jackson, which is 2 hours away, or Casper, which is also 2 hours away. So anyways, talking about the patient. So the patient is a 67-year-old female. She was sent to us with a referral for lumbar spondylosis without myopathy of the lumbar sacral region. But her chief complaint is that she has bilateral hip pain. Past medical history, she has had total hip arthroplasties, one in 2009 and one in 2011. And then most recently, she had a cervical fusion in July of this year. So special tests and measures, manual muscle testing, we just found some moderate weakness throughout her lower extremities. Active range of motion within her hip and lumbar was pretty within normal limits. She did have a positive straight leg raise and slump test on the right. We did not at this time perform an EMG or nerve conduction study on her. Her referring orthopedic surgeon was kind of hesitant at first when we started doing the EMGs, but has since come around. But like I said, not to date, we have not done one on her. She was negative for SI joint pain. She did have a pelvic obliquity, no discogenic issues, some slight hypomobility of her lumbar spinal segments. And then she has a really interesting gait. It's kind of robotic, and she stands with a very wide stance. She has the lateral trunk lean to either side, and then at times she drags both feet, but it's more common on the right side. So then treatment to date, they did some therapeutic exercise, some general strengthening of her lower extremities, working on her motion, stretching, and flexibility. We incorporated some core stability, some nerve glides to get that sciatic nerve moving better, and some balance issues to help reduce her risk of falls from that little foot drops that she has. And then manually, they did some soft tissue mobs with her, some muscle energy techniques, and some passive stretching to her hips. So it's probably about a month into her getting some therapy. Progress to date. So I have her goals from her initial evaluation in comparison to her progress. And she honestly hasn't made any progress so far. So it's at this time that her main treating therapist approaches me about doing a diagnostic ultrasound of her right hip, because that's really her main complaint. Her orthopedic surgeon's convinced it's coming from her low back and not her hips, so he hasn't done any imaging of her hips to date. So going on to her images of her hip. So the first one I did was her right anterior hip joint. As you can see, there's a little poor interface of her joint from the total hips. But she does, as you can see here, have some effusion. So then looking at her psoas muscles in the lax and sax view, nothing too significant, but again, she does have that little effusion.
Uh,
Gets
Sarah, sorry to interrupt you. Just wanted to like spend a little bit time here so that we are on the same page and everyone understand these images. So like she said, this patient had history of total hip replacement. So you can see the bony interface on the first slide and also the next following slide that you have. So let's keep it here where you are right now. So the bony interface doesn't look normal. You don't see the normal head and neck area. So this is consistent with maybe we are not a little bit more into proximal aspect where you can see a little bit of joint, but this is definitely the area of the neck, and you can see there's prosthesis which is more hyperechoic on the left side, which is proximal, and the bone which is on the right side. But definitely this is not normal hip. So if you see something like this, and let's say you don't know if this patient had any surgery, the first question that you should be asking is if you ever had any surgery there, or do you have hip replacement. So it's not normal bony interface or bony landmark that you would see in the anterior joint space. And just above the bony interface, you can see there's low hyperpituitary. That's where that's the effusion of the anterior joint, and overlying the area is your iliopsoas muscle group that you're seeing on top of that. Um, now, now let's move to the next one. Next slide. Yeah. So on the left is long axis, on the right is short axis. So here on the right, you can get maybe one more image, and maybe you can move a little bit more over to the right side and get to see if you get what kind of image you would get here. Is this something like maybe there's another interface that you did not capture here, but definitely you can see the long axis and short axis are pointing towards some type of hip joint fusion, right? And another so this is not next comment that I'm going to make here is not on this image, but any image where you're looking at long and short axis. One of the clues that this is a long on the left, and so even if Sarah did not label this image as lax and sax, you should be able to say that which one is long axis and which one is short axis, because look at the muscle fascicles here, look at the alignment, and look at the muscle fascicles here. So you can see this is short axis, right? You can see the fascicles. You're looking like a bristle-like pattern, versus on the left where the muscle is more like linear fibrillar, uh, in fibrillar arrangement or pattern. Okay, so just wanted to point that out, and also look at the interface. So this is subcutaneous tissue. This is the interface between the subcutaneous and muscle fascia. That would be the fascia, and then you have muscle. Oh, I'm sorry. I'm pointing with my pointer, but I didn't realize that the screen you cannot see my pointer. So thank you, Sarah, for pointing that for me. So yeah, so you can go from top to down or down to up, whichever works. So go by interface, like you can go by skin, subcutaneous tissue, fascia, muscle, bone, or you can go work your way from down to up, like joint or bone, bony interface, joint space, overlying capsule, ligamentous complex, muscle, uh, fascia, and the subcutaneous tissue. Okay, moving on to the next one. Continue, Sarah.
okay. So when I got to looking at her greater trochanter, so here's the greater trochanter. I found this hypoechoic area. And at first I thought it was maybe a bubble in the gel. So I took a couple pictures, and it was still present. So then from here, to confirm it, I went to look at her glute med and glute min. So I just, on one, I slid more posterior, and on the other, I slid more anterior. And again, I had this hypoechoic area.
That's a significant swollen area.
That's right.
Did you want to talk about any of these slides, Mohini?
Yeah, I wanted to like go over. Do you have another slide of images after this?
Nope, those are all.
So let's show what the impression was, and then I'll go back to these images. Yes. So you can talk about the next slide, and then we'll go back to the images. Yeah.
Okay, so impression of the ultrasound. So there's a localized hypoechoic area in the lateral aspect of the right hip above the plane of the glute medius and glute minimus tendon attachments of the greater trochanter, suggested of a soft tissue mass. Further imaging with an MRI is recommended. And then we also noted the effusion in the anterior hip joint.
There's a lot of noise in the background.
Some beautiful singing. That was really nice.
So what was the soft tissue mass, or do you know?
Okay, so right after this impression, this patient was asked to immediately refer, without wasting any time, was sent to the physician to do further investigation of what kind of mass it is. So now let's go back to the previous, no, previous one. One more. Okay, so here, yeah, the first one. Yes, this is the one. So here you can see this is the short axis view on the lateral aspect, and you can see this big mass, right? And so right underneath the mass is your gluteal tendon, and underneath that is bony interface, right? And bone is not very sharply defined here. It doesn't look that bright. Now move to the next one, next slide. Now here in this slide, you can again see the bony interface overlying gluteus minimus and medius, and above that, the soft tissue mass is above these tendons, right? This tendon dash. So this, whatever this mass is, we don't know what it is, but it is definitely above the gluteal muscle plane. So it's important. So with ultrasound, you cannot say what type of tumor it is, what kind of mass it is, but what you can say is whether it's cystic or non-cystic. It's non-cystic, right? Everyone agrees with that?
Mm-hmm.
If it was cystic, what would you see here? An artifact.
Completely black.
You can say, some people can argue that this is black.
Posterior enhancement.
Possible septae in there?
Yeah. Was that?
Possible septae in the actual cyst?
Yeah,
Posterior enhancement.
That's right. Yeah, posterior enhancement. So you will see posterior enhancement underneath the mass. So that artifact helps you differentiate cystic from non-cystic. So
Can you say that again?
in these images, the current slide that you see, you can see the bony interface and then the tendon and the mass, right? If it was cystic mass, right underneath the cyst, you would see the tendon enhanced, or tendon will be much more brighter, or you will be able to see a fibular, some type of echo texture of the collagen there, and bone may be more sharply defined. Now go to the previous slide, one slide before this. Yeah. So here, she's on the lateral side, and I think this is where the maximum, she got the maximum width of the mass here. Now look at the bony interface here. The bone is not smooth and nicely defined. So if you have, I'm going to use a similar example, sorry, something that explains this phenomenon, but it's entirely different thing. So we know about cartilage interface sign or double contour sign, right? So when you have full thickness tear of supraspinatus and the supraspinatus is torn and there's fluid in that area, um, when ultrasound is going through each interface, it has less resistance to go through that area. That's why it suddenly hits the articular cartilage interface and you see the brightness, which you should not see if there was a tendon there, right? So that's because there's now less resistance, so you have more echo coming from a hypoechoic structure. Now what's happening here is now you have a structure which is solid, and so it's what it's doing is because this extra structure is sitting there, you're getting less ultrasound on the deeper aspect. So there's attenuation here, there's absorption of ultrasound. So the structure underlying this soft tissue mass is less enhanced. So that's why the bone is not sharply defined here.
So I've got a question here.
Yes, sure.
So would you say there is obviously a hypoechoic mass or a hypoechoic region with opacity?
I don't think I would use opacity. I wouldn't say opacity. Ultrasound is good saying something is cystic or solid. That's where we end. You can further define it if I don't know if we didn't see any vascularity, Sarah. Did we? No. I think you said there was no vascularity.
No, I checked with the color Doppler and there wasn't any.
Yeah. So I would say I wouldn't go too much into defining what kind of mass it is. If I'm able to differentiate whether it's cystic and solid, I think that's what ultrasound can do the best. Or you can say whether there was any vascularity within the mass that was seen, or where is this mass, which interface is this mass present. So we know this is in the fascial plane. This is underneath this. It's deeper to subcutaneous tissue, but it's above muscle and fascia plane. So this is somewhere, under the subcutaneous, but above muscle and tendon fascia plane. And these differentiation can help whoever is treating this patient or wherever this patient going further narrow it down to what kind of mass can it be, because there are different types of tumors which have origin in different tissues. So let's say I'm using some examples. Let's say giant cell tumor or xanthomas, they are present around tendon sheaths. So if you see them around tendon sheath, you would think, oh, it may be that. Of course, there's more testing that you need to do. You may need to do some biopsy or the CT or MRI or maybe contrast CT, contrast MRI. But with ultrasound, you want to define where it is, localize it. You define the echogenicity. It looks more or less homogeneous, not that heterogeneous. So opacity, I don't think we can use that term, or maybe you can use, if you want to use something more to define it, you can say that it's not that heterogeneous actually. Heterogeneous I would use when there are like too many textures. If it's like mixed echoic, I would use that. It looks more like there are some areas that I see here, like tiny hyperechoic bright spots, but it's not a whole lot. If you really want to,
are you pinpointing this to the GD bursa?
So this is not, so that's a good question that you asked. So I'm glad you asked that. This is not trochanteric bursa, because that would be posterior. Remember, there are three facets: anterior, lateral, and posterior. And trochanteric bursa is on the posterior facet. So we are not that posterior, on the lateral side, and we are actually more anterior-lateral, because her images, Sarah's images, are on the lateral and anterior aspect, and you're looking at gluteus medius and minimus tendon underneath. So that means we are not that far posterior. So this is, I think that was, Sarah, that was your question, right? You initially thought this is a trochanteric bursa, right? That was one of the
or a potential cyst.
Yeah. So
did you take dimensions of this?
I did not.
Yeah.
You know, a lot
Uh,
of lipomas are in this area too.
there are lipomas, that's true, but lipomas are usually non-symptomatic. This patient
And
was
she was
was that
painful in this area.
yeah, she was painful on this side, and also there are other the clinical presentation that she explained so far. Um, she had hip problem more than any lower back or any radiating pain. So we can get back to this again, but I think I would let Sarah continue with the rest of the presentation, and then we can come back to ultrasound images again for more discussion. So over to you, Sarah.
Okay, so after I got the diagnostic ultrasound impression back, I talked to her about it, and we got her scheduled for an MRI. So the results of the MRI, sorry, differential diagnosis, we kind of talked about this, but her MRI results, the first one, they confirmed the fibrous mass in the subcutaneous tissue of the lateral hip, but they wanted to do a second study with dye. So about a week later, she got the one done with dye, which again confirmed the partial enhancement of the subcutaneous mass, and malignancy should be considered as a possible etiology. And then below that, they took some measurements of the dimensions, the diameter, that it was heterogeneously.
Yeah.
So from here, her orthopedic surgeon sent her to a specialist for a biopsy. The biopsy actually came back negative. But interestingly, she had a blood test that was positive for cobalt poisoning.
Wow.
So her final diagnosis is that she has metallosis with cobalt poisoning. So metallosis is the buildup of metal debris in the soft tissue, which enters the bloodstream, causing metal poisoning. It commonly occurs in metal on metal joint replacements. Common symptoms, I listed a few. So she had the increased hip pain, changes in gait mechanics, and then earlier this year she had that cervical fusion for radiating symptoms into her upper extremities. So a little more about the metallosis. Metal ions can cause the following: general hypersensitivity, so like a skin rash, cardiomyopathy, neurological changes, psychological changes, renal function impairment, and thyroid function or dysfunction. Patients that it's more common or at higher risk of having device issues with include patients with bilateral implants, patients with resurfacing systems with small femoral heads, female patients, those receiving high doses of corticosteroids, renal insufficiency, a suppressed immune system, suboptimal alignment of the device, a susceptible metal sensitivity, patients who are severely overweight, or patients on the other side of the spectrum who are highly have high physical activity. So patients with metal on metal hip prosthesis should therefore be followed up carefully, specifically looking for any changes in neurological, cardiac, respiratory, or endocrine function. And then the only way to fix this, to drop her cobalt levels, is to have a revision of her total hips bilaterally. So she's in the process of getting that scheduled. And that was all of my presentation, so I don't know where you want me to go back, Mohini.
Okay, so this patient now is going to get THA revision. So I think this is a great case, right? And Sarah, I think you did the right thing by doing ultrasound. And imagine, not doing ultrasound, not finding about this, and continue with therapy, and nothing happens, and nothing was changing. Sarah presented initial and progress, and I think this saves the time and makes the process so efficient, because now you can pick up these problems way early and not waste money on and something which is not going to help the patient, and you can direct them in the right direction. And if she was not diagnosed early on, she can go on to get maybe there would be cobalt poisoning or some more severe side effects because of that metallosis and cobalt uh, poisoning in the body. So uh, that saved the patient a lot of trouble in the future. So anyone has any comment and questions before we go back and look at the images one more time?
Yeah, I do, Mohini. My question is, did she get the cobalt poisoning? Was it from the metallosis?
Yeah, that was one of the risk factor with metal on metal transplant. And if you go back to the risk factors, Sarah, can you go back to the risk factors? I think she had 3 of them. Yeah, see, look at that. Out of them, she had bilateral implants, and she's female. I don't know about others, but she definitely fits with like 2 of these criteria for adverse local tissue reaction.
I'd like to make a comment here real quick.
Yes.
So you did fantastic on that. I mean, you basically saved this person from probably having lumbar surgery and a bunch of other stuff happening to her. And I mean, that's, this is what I call the hokey pokey. That's what it's all about. You did a fantastic job on that. And that's really highly commendable that you did that. It's awesome.
Yeah, this is a good case, and it's good that you're asking, because I know you talked about heterogeneous. You wanted to comment that it's a heterogeneous hypoechoic mass, and go back to MRI slide, Sarah. So the MRI is saying that there is heterogeneous hypointense mass, right? But also it is largely dependent on the type of probe you're using, what frequency it is. So I think the maximum that most of the people have is 15 megahertz. Which one do you have, Sarah? Is it 15? I think it's the 15 one. 6 to 15? Yeah, maybe if you go a little bit higher, maybe you can pick that heterogeneous signal that they're saying, but I don't think it's still going to change much, because whatever it is, it's the same. The mass that's there is not something that needs to we don't need to tease out into like histopathology of that. It is because of metallosis and cobalt poisoning, but the language that you use in ultrasound and how you define it can sometimes be dependent on the type of equipment you use, or what type of frequency you have, how sensitive is your Doppler, because if you use power Doppler, you can get very slow flow compared to just regular Doppler. So just wanted to point that out. But yeah, I agree, this is a great case.
Sarah, did you use a curvilinear probe?
No, we don't have a curved probe. And this was actually my first hip that I've imaged on a patient.
You did a good job.
Oh,
wow. For sure.
What a one to start with.
Yeah.
Yeah, that's a pretty good size mass too.
Yeah. I think that if maybe with curvilinear you could see the whole thing, and maybe not, because it's more on the lateral side, and you may have to stitch the images together to get the whole thing in one. Yeah, I think that's one thing that you could have done. You could have measured it. Not that it's going to change anything, but the most important thing is you picked the patient at the right time and guided them in the right direction. So that's the most important thing. Yeah, but any soft mass you want to measure it. Yes.
So a question on the measurements. So
Yes.
for instance, like it's like the suprapatellar effusion. You don't want to measure that because that's an area that you can push down on and fluid goes in and out of it. But on this one, since it's fluid that is probably more contained, it's okay to measure that?
Oh, this one is not fluid. This one is a soft tissue mass. It's solid.
Okay. So what I'm saying is, so a cyst like this would be easy. That's what you want to measure. You don't want to
Yeah,
measure.
this you can measure
You know.
because it's contained. Yes, yes, that's right.
Okay.
And also for suprapatellar effusion, if you want to measure it, you can measure it, but you have to make sure. So let's say you want to monitor the progress of the patient, how their effusion is improving with whatever you're doing with them. Let's say you want to see them again in 2 months or 3 months or whatever time interval you decide. Whichever position you scan them in, you have to know that. Let's say if it was 30-degree flexion, you want to measure them in the same. So all those positioning and everything else should be the same. And so you can still measure the fluid that can move if you keep everything else constant. Like no muscle contraction, what is the position of the patient, what is your pro position, and how much pressure you're putting. You can still measure it.
So I have a
The
quick
problem is
question.
that when you, oh, sorry, just one more thing. The problem is when someone else measures that. So let's say you measured suprapatellar effusion, which can move, and now they go, let's say, to somewhere else, and they measure it next day or maybe the same day, and they say, oh no, it's not that big, it's this small, or maybe it's more. That is not reliable. If it's the same operator, same settings, you can use it.
Mm-hmm.
Yes, Brian, yes. Go
No,
ahead.
the question I had, I noticed that the hip replacements were 2009, 2011, and I know there's been a lot of hips that have been on recall, one brand in particular. How do we? I know this is kind of way off the topic, but how do you advise a patient like this? Because there's tremendous amount of lawsuit based on the components of a hip replacement, other than just providing the documentation to say, hey, we definitely found something indicative of a mass here. You know, there's awards that are out there for these patients to actually have their hip replacements, the new ones, paid for. So just kind of a point of notice, I don't know when those recalls were, but I think they were predated 2012, just as an FYI. So I wonder if this is what we would see on other cases, because it seems like this is one of those cases where we're seeing the metallosis and these hips were actually recalled. So are you familiar with a lot of these recalls, Mahini?
I'm not, but you know what? You don't have to worry about it because we are not the ones who said this is metallosis. They said it, whoever did it.
No, of
So
course.
what you need to do is you just guide them in the right direction. Okay, you have a mass and this needs immediate attention. So you go, you're not wasting any time, go investigate further, and then let them do the biopsy and the blood test and the MRI to point out, okay, this is what it is. I think our role is we don't have to take any extra stress or any liability. We just have to decide what's good for the patient and for you. You don't want to keep this patient for too long in your practice. Yes, I think that's what my take is here.
Okay.
Anyone else has any comment here?
To check the left hip and just compare the two?
Yeah, that would be a good thing to do, right, Sarah?
Yep. But I did not.
This patient is getting a revision, so it's okay. Let's be it. Yeah, because she was sent immediately, so I don't think there was any window for Sarah to do the left side. And yeah, she has a bigger concern, so maybe you can do a follow-up if you still have this patient.
And do her left hip?
Yeah, just to see. Is she getting revision in both? I'm assuming both.
I don't know if when she's doing them. I know she's gone down to Utah to talk to a surgeon about getting them done. I don't think anything's scheduled yet.
But she will have to have that because she cannot have cobalt in blood for too long. Okay, all right. So that'll be nice. Maybe you can do a follow-up on this case if you are still in touch with this patient. Very good. Any other comments or questions? Or
I have
Is
another
there a
question.
reason why she went to Utah? Was the original surgeon from Utah, Sarah? Was that just she decided to go with somebody new instead of the one that she's seeing?
I don't know if she had both done by the same person. I didn't ask. And I think she's going to Utah because I don't think anyone specializes around here for the revisions.
Okay.
Hey, Mohini, could you just go with this slide here, this scan, kind of go back over the posterior enhancement with your, show, I guess, Sarah, you'll have to use your yeah, just go back over that again.
Okay, so let's look.
As I look at that, I go, oh, that looks like a soft tissue mass to me, but you were.
That's right. You're thinking it in the right direction. Yeah, that's a soft tissue mass. So if it was not a soft tissue mass, what you would see is you will still see anechoic or hypoechoic. And anechoic, hypoechoic can sometimes be used interchangeably. Hypo is less, and this less is not defined in quantity. How less? Hypo is less. So whichever is less, giving less echo is hypoechoic. And sometimes the fluid is not a simple fluid. It's serosanguinous. Maybe there's some bleeding there. Maybe it's viscous and it's thickened. So cyst can also have complex presentation. But what the defining feature is, and again, it depends what's around that cyst or mass. So in this present picture that you're seeing here, current picture, if this soft tissue mass, this round hypoechoic mass was cystic, you would see hypoechoic or anechoic signal, and underneath this mass, you will see brightness or enhancement. And right underneath is the tendon, which is looking like a dark band underneath. So just above the bone, so that's the bone, the hyperechoic is the bone, and just above the hyperechoic is hypoechoic tendon. Because remember, she's cross short axis on the lateral side. So that you're getting a little bit of short axis, oblique short of the tendons. In this view, you will be able to see the tendon better because now you have a structure overlying the tendon which provides a better contrast. So that gives you a good view of the tendon, but the tendon doesn't look good here. It's darker because this solid structure is absorbing or attenuating the ultrasound, so you're not getting much penetration. And that's why, because you're not getting much penetration, everything under that is like fuzzy, not very clear. So that's what it is. And second thing, in this structure, because there's no posterior enhancement, and other thing is like you can still see some echoes inside. There are some internal hypoechoic echoes within it, right? You can see this like bright spots. They're not so bright, but they're relatively within the you can see that. So this is a mass. This is a solid mass. And then two more things that you can do is one, compressibility test. You can push with your probe and see if there is fluid in it and it's communicating with the joint. You can push the fluid in and out of the joint into the area, or you can check color Doppler. Put the square, the rectangle over there, and see if there is any vascularity. If there's any vascularity, then that is for sure you're looking at solid mass, and this is not cystic, because if it's cystic, it's like a water bubble. You have fluid inside it, but there are no blood vessels inside it. But soft tissue mass can have vascularity in it. And all soft tissue masses have vascularity. Now the question is if it's big enough for your ultrasound to detect. Even if if you look at if they operate and if you get to see the soft tissue mass, you will see some vascularity in it because something is feeding that soft tissue mass to grow. Now it has to be certain caliber for ultrasound probe to detect it. So it's not as much for ultrasounds. If the flow is very slow and these are all capillaries, you may not be able to detect them. But there is some vascularity there. Okay. Any other question?
That was really good, Sarah.
Yeah, great job.
And I don't think most people know she is 35 plus weeks pregnant. So that's good job, Sarah.
Congratulations.
Congrats.
Thank you. Almost there.
There, 4 more weeks.
Oh, 4 more weeks. Okay.
Well,
Good.
hang in there and Merry Christmas.
Yes,
Yeah.
very good. Okay, thank you, everyone.
Thank you.
That was a good
Thank you.
discussion.